Good evening, everyone. Today we are going to talk about pediatric hypertensive crisis. It's very important to identify and treat appropriately. It is based on the recent guidelines available. Before we move on to how to diagnose and treat, let's talk about terminology and definitions. Hypertensive crisis is sudden and abrupt, severe elevation in BP from baseline with a life-threatening potential to cause rapid end organ damage. Hypertensive emergency when BP elevation is accompanied by evidence of severe symptoms and end organ damage. Hypertensive urgency wherein the BP elevation is accompanied by minor or no symptoms are present. That's the difference between emergency and urgency. 2017 guidelines use the term acute hypertension instead of urgency and emergency. So in children and adolescents, there is no clear definition for severe hypertension. Nevertheless, patients who present with acute severe hypertension will have BP elevation well above stage 2 hypertension threshold. The clinician should be concerned about the development of these complications when the child's BP increases 30 millimeter or more above the 95th percentile. So how prevalent hypertensive crisis in children is? It's difficult to estimate given the lack of uniform definition and methodological approach in children. 12 to 14% of patients with hypertensive crisis happens in children 1 year or less. Vast majority of the hypertensive crisis happens in children older than 7 years of age. I think the reason being only in that age group we check the blood pressures, even though American Academy of Pediatrics recommends checking blood pressure more than 3 years of age. 44% were older than 13 years. There is a male predominance in hypertensive crisis, and of late there is an increased association with increased BMI. So what is the etiology for hypertensive crisis? In adults, very easy, non-adherence to prescribed medication. They don't take the medications as it was prescribed. Drug overdose. Sudden withdrawal of antihypertensive medications, very important because when we prescribe antihypertensive medications, we need to give anticipatory guidance that they cannot stop the medication or quit the medication cold turkey. In children, it's attributed to secondary causes, most of the hypertensive crisis because of renal causes than primary cause as it happened in adults. In neonates, oftentimes you see coarctation of aorta, renal vein or artery thrombosis, and polycystic kidney disease. Sometimes the rare diseases like mesoblastic nephroma, iatrogenic hypercalcemia, and drugs such as phenylephrine eye drops and rarely theophylline overdose. In older children and adolescents, you will see substance abuse, specifically with cocaine, amphetamines, hallucinogens, drug overdose, over-the-counter cold remedies containing pseudoephedrine, phenylpropanolamine, non-steroidal anti-inflammatory drugs, and monoamine oxidase inhibitors. Of late, you have seen consumption of energy drinks associated with severe hypertension in adolescents and young adults. These are the different causes of secondary causes of hypertension in children. When I was in India, we used to see lots of glomerulonephritis, most of them PSG and post-streptococcal glomerulonephritis, and also glomerulonephritis of other origin. Reflux nephropathy is another bigger category. Obstructive uropathy, polycystic kidney disease, thrombotic microangiopathy, lupus nephritis, especially in adolescent girls, renal artery stenosis, acute kidney injury, end-stage renal disease, and status post-kidney transplantation. Cardiovascular causes are very important in smaller kids and neonates. especially coarctation of aorta and systemic vasculitis. Malignancies such as pheochromocytoma, Wilms tumor, neuroblastoma, status post bone marrow transplantation. Endocrine causes like Cushing syndrome, thyrotoxicosis, rare forms of congenital adrenal hyperplasia. The most common form do not have hypertension, but I think 11 hydroxylase have hypertension. Neurologic disorders like dysautonomia, Guillain-Barré syndrome, increased intracranial pressure, immunologic, systemic lupus, psoriasis, and PAN. Medications use, you need to get the good history of antihypertensive or other medication like over-the-counter cold remedies, amphetamines, non-steroidal anti-inflammatory drugs, anabolic steroids, corticosteroids, calcineurin inhibitors, and erythropoietin usage, rapid withdrawal of antihypertension. Those needs to be elicited in those patients because it is easy to remedy. Monogenic hypertension can be seen in Liddle syndrome, Gordon syndrome, apparent mineralocorticoid excess, and glucocorticoid, remediable aldosteronism, and of course, primary in patients with obesity and high renin hypertension. So, how does the pathophysiology works? When there is an elevation in BP, the activation of renin-angiotensin system and oxidative stress and endothelial dysfunction happens. That results in protein fragmentation and formation of new antigens. It activates T cells. It promotes the entry of inflammatory cells and release of cytokines that causes vasoconstriction and sodium and water retention that perpetuates elevation in BP. So it is like a closed loop feedback. So you need to control the BP in order to prevent acute severe hypertension. What are the clinical
Wow.
presentations?
Mm.
So what are the clinical presentations? The most common is neurologic. 55% of the patients present with headaches. 46% present with dizziness. 36% present with nausea and vomiting. 16% with altered mental status. 11 to 20% of the patients present with seizures. Sometimes it can present with facial palsy and hemiplegia. It can also present with PRES, which is posterior reversible encephalopathy syndrome. What is posterior reversible encephalopathy syndrome? It's often seen in patients post chemotherapy, post transplant, autoimmune diseases, immunosuppressive drugs, and end stage renal disease. This condition requires tight PP control, otherwise, they can lead into posterior reversible encephalopathy syndrome. The clinical presentations of PRES is as follows. Initially, they present with headache, nausea and vomiting, altered mental status, seizures, cortical blindness, and focal neurologic deficit. Oftentimes, the diagnosis is done by MRI that shows bilateral symmetrical changes of white matter in the occipital parietal regions. PRES, by definition, is a reversible condition. That but sometimes it can lead to long-term neurological sequelae. So it's not as benign as it had been thought once. There are reports of cerebellar tonsillar herniation requiring ventriculostomy. What are the differential diagnoses of hypertensive encephalopathy? Intracranial hemorrhage, cerebral thrombosis and infarction, uremia with encephalopathy, brain tumors, encephalitis, pseudotumor cerebri, and anxiety of hysterical states. What are the cardiovascular manifestations? It can present as congestive cardiac failure. The symptoms would be dyspnea on exertion, peripheral or pulmonary edema, and gallop rhythm on auscultation. They can present as chest pain and tenderness. In fact, 1/3 of the patient present with chest pain and tenderness. And quarter patients, 13 to 26%, will have left ventricular hypertrophy. So having an EKG and the echo is very important in patients with hypertension. There is another study. All patients with severe hypertension had cardiomegaly and 9% had cardiac failure. So EKG and the echo is a must in patients with acute severe hypertension. They can also present with visual abnormalities like retinal infarcts, hemorrhages, optic disc edema, cortical blindness, acute ischemic optic neuropathy, and visual disturbances with increased intracranial pressure. Acute visual changes often seen in patients with encephalopathy with plus. Renal hypertension, 18% had hypertensive retinopathy. So all these patients need to have their retina evaluated. There is another study, 36% of children with severe hypertension had papilledema. So eye examination must in all acute severe hypertension. It can present with acute kidney injury, hematuria, and proteinuria. Patient with unilateral renal artery stenosis might develop hyponatremic hypertensive syndrome. How does that happen? Because the increased blood pressure, hyperfiltration happens that results in pressure diuresis and natriuresis on the contralateral kidney. They're present with polyuria, polydipsia, and headaches. When you do the lab test, it will show hyponatremia, hypokalemia, hypochloremic alkalosis, and proteinuria. In neonates, the presentation is a little different. They present with irritability, feeding problems, failure to thrive, tachypnea, apnea, cyanosis, congestive cardiac failure, lethargy, and seizures. Sometimes neonates can present with cardiogenic shock. How do you evaluate? Number one, you need to differentiate between emergency and urgency. Initial evaluation needs to be done within minutes. Brief history and physical exam because blood pressure management and prevention of end organ damage is a must. In other upcoming slides, we are going to talk about lab and radiology. So the patient presents with palpitations, sweating, and flushing, think in terms of catecholamine producing tumors. Hyperthyroidism can present with exophthalmos, tachycardia, diarrhea, and weight loss. When you have an abdominal mass present in examination, think in terms of neuroblastoma, Wilms tumor, autosomal recessive polycystic kidney disease, multicystic kidney dysplasia, and obstructive uropathy. In patients with end-stage renal disease and glomerulonephritis, examine for fluid overload. Renal artery stenosis can be picked up by abdominal bruit, but most of the time you need to have a Doppler ultrasonogram to make the diagnosis of renal artery stenosis. Cushing syndrome can present with moon face, truncal obesity, striae, and hirsutism. Aortic coarctation can present with weak peripheral pulses, low blood pressure in the lower extremities. Brain injury and trauma can have bradycardia, irregular breathing, or apnea. When you do the lab testing, get the complete blood count, renal function test, thyroid function test. In selected cases, plasma renin activity, cortisol, fractionated plasma metanephrines. Pregnancy test in adolescent girls. Urine needs to be tested for urine analysis, sometimes cultured, especially in reflex nephropathies and urine toxicology if you suspect substance use. Radiologically, renal ultrasound and Doppler, echocardiogram, head CT, and MRI if signs of encephalopathy is present. Chest X-ray in pulmonary symptoms. CT and MRI in the suspicion of renal artery stenosis. Of course, one need to have a fundoscopy examination. So what are the treatment aims in patient with acute severe hypertension? There are two goals. One, preventing or treatment of the life-threatening complications of hypertension, mainly neurologic, ophthalmologic, renal, and cardiac. Immediate intervention effectively but safely lower the BP. They need to be treated in ICU, especially when the patient has hypertensive emergency. There are certain important considerations you have to have when you are treating with acute severe hypertension. Use IV drugs because it can give prompt delivery of the medication and titration of antihypertensive medications. All these patients need to have intra-arterial access for invasive blood pressure monitoring and monitoring of the vital organs, including Glasgow Coma scale, EKG, telemetry, urine output, and kidney function. Supportive therapy for possible life-threatening complications like anticonvulsive therapy and cardiotrops. So these are all must when you are treating with acute severe hypertension. Then other things needs to consider what route one should use and antihypertensive, what drug you should use, and how fast the BP should be lowered, and what is the BP target. An hypertensive emergency should be treated with IV drug, preferably by intravenous continuous infusion. There are no comparative studies investigating what is best class of antihypertensive medications to use in case of hypertensive crisis in children. Selection of an initial medication is often based on physician preference and experience as well as drugs availability. Consider following things when you're choosing the medication. It should act rapidly, it has a good safety profile, and ease of use. There are two phases in BP lowering. I mean, when you are treating acute severe hypertension. The first phase, lower the blood pressure by no more than 25% of the planned BP reduction over the first 6 hours. That means you need to have planned BP reduction first. Then 25% of the reduction can happen or should happen in the first 6 hours. The second phase lasts for 24 to 48 hours. During that time, the remaining 75% decline need to happen. One should remember a faster normalization of severe hypertension must be strictly avoided because it can cause more harm. Very important point to remember. Why that happens? In patients with chronic hypertension, with a significant duration of blood pressure, the autoregulation maintains perfusion in the most vulnerable places like brain, kidney, cardiac, renal. So, when it is already adapted for chronic hypertension, bring down real quickly and have the brain, it can cause cerebral ischemia. In kidney, it can cause AKI, acute kidney injury. In coronary, it can cause acute coronary syndromes. The same token, when it exceeds autoregulation, it can cause diffuse endothelial injury, retinal damage, cerebral edema, so on and so forth. So you have to remember the patient had chronic hypertension, you need to reduce the blood pressure the first 6 hours, 25% of the planned BP, and the remaining 75% needs to be done over 24 to 48 hours. So let's take the example of 15-year-old boy present with systolic blood pressure of 190 millimeter of mercury. The goal of reduction is 130 millimeter of mercury. That means 60 millimeter of reduction over the next 48 hours. The first 6 hours, we want to reduce 15 millimeter of mercury. That is 25% of 60. The next 24 to 48 hours, BP should be gradually decreased from 175 to 130 millimeter of mercury. If BP is decreased faster than the proposed, it happens sometimes, then treat him with fluids and vasopressors to prevent precipitous drop in blood pressure. It's very important. In adults, they have a little bit different parameters. We are going to discuss this one. Adult hypertension, including pregnancy-related hypertension, next week. Okay, let's talk about antihypertensives. Number one being vasodilators, nitroprusside. It's one of the most commonly used drugs in acute severe hypertension. What are the favorable factors? It is efficacious, rapid onset of action, the rapidity of the withdrawal of action in case of relative hypertension. If there is hypertension, you can stop, then blood pressure comes back up. It's a direct arterial and venous vasodilator. The side effects, if it is used more than 24 to 48 hours, it can cause cyanide toxicity because it causes accumulation of thiocyanate. It can cause methemoglobinemia, metabolic acidosis, or seizures. Cyanide is very effective medication in controlling blood pressure, but one should have a ability to check for thiocyanate levels, methemoglobinemia, metabolic acidosis. Second is hydralazine. It's a direct arteriolar vasodilator. It decreases BP by decreasing systemic vascular resistance. It has a negative inotropic effect on the heart, so it causes reflex tachycardia, activation of RAS, renin-angiotensin-aldosterone system, and sodium retention. Hydralazine can be used orally. Diazoxide. It's a direct vasodilator that increases permeability of vascular smooth muscle membrane to potassium. Has a quick hypotensive effect without significant adverse effects in small dosages in children. It's unavailable in many countries. Nitroglycerin. It's a nitric oxide donor and a potent vasodilator which reduces preload and cardiac output. It's not used as a first-line treatment. It's commonly used as an adjunct treatment in adults with acute coronary syndromes, oftentimes used in adults in acute coronary syndromes. Calcium channel blockers. The most commonly used is nicardipine. It's a second generation dihydropyridine calcium channel blocker. It induces vascular smooth muscle cell relaxation and peripheral vasodilation. The adverse effects are tachycardia, flushing, and palpitation. Other group is adrenergic blockers and the agonists. Labetalol is alpha-1 and beta-adrenergic blocker. It reduces peripheral vascular resistance and has little effects on cardiac output. The adverse effects are negative inotropic effect and bronchoconstriction. Esmolol. It's ultra-short-acting cardioselective beta-1 adrenergic blocker. It significantly reduces BP within the first 6 hours of administration. This is the only one drug that had been evaluated in the randomized controlled trial in controlling acute severe hypertension in children. The side effects are bradycardia, hypotension, and wheezing. At higher doses, its beta-1 selectivity is lost and also peripheral beta-2 receptors are activated, resulting in bronchoconstriction, and it should not be used in acute decompensated heart failure. And also, without saying, it should not be used in patients with the status asthmaticus or very severe bronchoconstriction. Another group, angiotensin converting enzyme inhibitors. Enloprolate is the only IV-AC inhibitor on the market. It's very effective in renal parenchymal, renal vascular, or high renin primary hypertension. The adverse effects are hyperkalemia, acute kidney injury. So it is contraindicated in bilateral renal artery stenosis or stenosis of the solitary kidney, and in patients with volume depletion, it's better not to use AC inhibitors. Then diuretics. Furosemide is a loop diuretic effective in children with volume-dependent hypertension. It's used in oliguric acute kidney injury, glomerulonephritis, congestive cardiac failure. It causes diuresis and natriuresis. Thereby, it decreases blood pressure. That adverse effects of diuretics are hypokalemia and volume depletion. Another group is adrenergic blockers and agonists, doxazosin and prazosin. Those are alpha adrenergic blockers. It's mainly used in catecholamine-induced hypertension, like pheochromocytoma. Used in preoperative management before surgical resection of tumor to prevent complications not only from hypertension but also from catecholamine release. So, how do you approach when the patient comes with acute severe hypertension? Number one, you need to identify whether the patient has hypertensive emergency or hypertensive urgency, even though the latest guideline use the phrase acute severe hypertension. This is very important in order to treat how to go about it. When there is a hypertension emergency, place an IV and start IV infusion to control the blood pressure. If you place them in hypertensive urgency group, and if they can able to tolerate pure drugs, use pure drugs. They can't use IV infusion or bolus. First step in emergency, the first 6 hours, decrease the BP by 25% of the planned blood pressure decrease. As you mentioned earlier, when you want to decrease 60 millimeter of mercury, the 25% of 60, 50 needs to be decreased over 6 hours. The second step is decrease the remaining 75% between 24 to 48 hours. Decrease BP gradually around 95th percentile for age. During that time, add pure drugs. The pure drugs do take time, especially when you use amlodipine. It's once a day. It takes few days to reach the therapeutic level. If you use the shorter half-life patients, you may get the control within 2 days. The third step is that is after 2 days, decrease BP less than 95th percentile. This is a schema for dealing with acute severe hypertension. These are the different medications with route, dose, onset of action, and side effects enumerated. This slide talks about direct vasodilators, diazoxide all the way to nitroprusside, alpha blockers, pentolamine, phenoxybenzamine, prazosin, doxacin, beta blockers, esmolol, alpha and beta blockers, labetalol, and peripheral alpha blocker with 5-hydroxytryptamine receptors, uridipol, and central alpha agonist, clonidine, AC inhibitors, enalaprolate, captopril, calcium channel blockers, clofidipine, isradipine, nicardipine, nifedipine, diuretic, furosemide, dopamine receptor agonist, phenyldiprate. I'll leave this one in the screen for a few minutes, now few seconds, and I'm going to talk about the most commonly used drugs according to American Academy of Pediatrics and their dose and side effects. This one is comprehensive, a list of all the medications used in acute severe hypertension. I really like this particular slide. Okay. So this is again two groups AAP published. One, the antihypertension used for emergencies and another group for urgencies. I'm going to divide into emergency group. These are the most commonly used drugs. I'm going to tell you what we use very often in the United States across the board. Esmolol. Esmolol is often used. It's a beta adrenergic blocker in all post coarctation surgery patients. They all have high severe blood pressure. We use like esmolol to control the blood pressure. It's short acting, constant infusion is preferred, can cause profound bradycardia. Hydralazine we use, but not as a first. Usually it's for intermittent dosing, direct vasodilators. The dose is zero point 0.1 to zero point 0.2 milligram per kilogram per dose, up to zero point 0.4 milligram per kg. Intravenous can be given intramuscular, give every 4 hours when given intravenous bolus. But there is no role for intramuscular, especially when you are dealing with acute severe hypertension, even though it can be given intramuscular, but intravenous. Labetalol, commonly used. It's alpha and beta adrenergic blocker. Bolus 0.2 to 1 milligram per kg per dose, up to 40 milligram per dose. Infusion 0.25 to 3 milligram per kg per hour. Intravenous bolus or infusion, and oftentimes used for bolus. Asthma and overheard heart failure are relative contraindications. Okay. Nicardipine is the most commonly used drug. So if you wanted to remember one medication out of this one for immediate control of blood pressure is nicardipine. I will tell you why. It's a calcium channel blocker, bolus 30 mics per kg, up to 2 milligram per dose. Infusion 0.54 mics per kg per minute. Typically, we don't give a bolus. We start with infusion and titrate up to keep the blood pressure to the desired level. Intravenous bolus or infusion can be given. It causes reflex tachycardia and increases cyclosporin and tacrolimus levels, especially in transplant patients. Sodium nitrite, sodium nitroprusside, direct vasodilators, very potent drug. And starting dose 0 to 3 mics per kg per minute, max 10 mic per kg per minute, intravenous infusion. The issue with nipride is you need to monitor cyanide levels, especially when you give an infusion more than 72 hours or in patients with renal failure. And you need to co-administer sodium thiosulfate. It nullifies the cyanide toxicity. So go-to use nicardipine is much easier because you don't have that kind of monitoring needs to be done like nipride. And typically we use these two, nicardipine and labetalol as a bolus. It works beautiful. Another group in hypertensive urgencies, clonidine central alpha agonist, 2 to 5 microgram per kilogram, up to 10 microgram per kilogram every 6 to 8 hours. Adverse effects, dry mouth and drowsiness. Make sure that. Pheneldiprime, dopamine receptor agonist, 0.2 to 0.5 mics per kg, up to 0.8 mics per kg per minute, intravenous infusion. Higher doses worsen tachycardia without further reducing blood pressure. So the lower dosages, it works. If you have to go up on it, then use something else. Hydralazine, direct vasodilators. It's a potent vasodilator to bring down the blood pressure. We use as a second line. So, for example, if labetalol not controlling blood pressure, we throw in hydralazine. 0.25 milligram per kg per dose, up to 25 milligram per dose every 6 to 8 hours can be given oral. And the half-life varies with genetically determined acetylation rates. Isodipine, calcium channel blocker, 0.05 to 0.1 milligram per kg per dose, up to 5 milligram per dose given every 6 to 8 hours. Exaggerated decrease in BP can be seen in patients receiving azole antifungal agents. I like isodipine better than amlodipine. Amlodipine is 36 hours half-life. Minoxidil, direct vasodilator, 0.1 to 0.2 milligram per kilogram, up to 10 milligram per dose every 8 to 12 hours. Most potent oral vasodilators and long-acting. So management of hypertension crisis in specific settings. When the patient comes in, you do not even know what is the underlying is. You control the blood pressure, of course. When you are doing that one, we will know what caused the hypertension. During initial phase, IV infusion of vasodilators or calcium channel blockers. When the cause is established, treatment should be tailored towards pathophysiological mechanism. Most common being glomerulonephritis. Children with acute glomerulonephritis experience acute increase in blood pressure, and also they are at high risk of post-reversible encephalopathy syndrome. You have to remember that. So faster lowering of high BP and glomerulonephritis is okay because there is a minimal risk of organ hypoperfusion. They have not had a good equilibration happen yet. So it is okay to bring down the blood pressure to normal 10 levels. But it's okay to go slow too. It all depends on what the presentation is. They have a sodium and water retention, so they may benefit from diuretics. So diuretics and lowering the blood pressure. AC inhibitors are not recommended as they have low efficacy due to sodium and water retention and the risk of hyperkalemia. Second group is acute kidney injury. Loop diuretics works good. AC inhibitors are not recommended. In severe oligoanuric acute kidney injury, when diuretics are ineffective, dialysis with ultrafiltrations may be indicated. Renovascular hypertension. AC inhibitors are contraindicated in bilateral renal artery stenosis or stenosis of solitary kidney. In the absence of contraindications, AC inhibitors are very potent antihypertensive in high renin hypertension. They should be used with caution in neonates because of acute kidney injury, because most of the neonatal hypertension have high renin levels. So when you use AC inhibitors, be careful. Beta blockers are preferred second-line therapy due to their ability to reduce renin release from the kidneys. So ACE inhibitors plus beta blockers. Pheochromocytoma. Alpha-adrenergic antagonists like phentolamine is a drug of choice in children with pheochromocytoma. Once alpha blockage is achieved, the children experience tachycardia, so beta blocker may be used in combination. But beta blocker should not be used as a first-line therapy without alpha blockers. Otherwise, unopposed alpha-adrenergic stimulation can further elevate the blood pressure. Second and third line, calcium channel blockers. Coarctation of aorta. Esmolol is frequently used in infants and children with aortic coarctation. And of course, we switch over to enalaprolate or AC inhibitors. This would typically start with esmolol and start enalaprolate, subsequently captopril or lisinopril. Hypertensive crisis in newborns. It should be treated exclusively with IV infusion or short-acting antihypertensives. The drugs often used are nitroprusside, labetalol, esmolol, nicardipine, istradipine, clonidine, and hydralazine. AC inhibitors must be used with great caution in neonates. So what is the prognosis of children with hypertensive crisis? One, because the consequences of hypertension itself. Cardiac consequences are they often have left ventricular hypertrophy. Sometimes they can have frank congestive cardiac failure and hypertensive cardiomyopathy. Neurologically, they can present with seizures, facial palsy, hemorrhage, papilledema, post-reversible encephalopathy syndrome, and altered mental status. Kidney-wise, they can have hypertensive nephropathy like acute kidney injury, proteinuria, sometimes chronic kidney disease. They can have blindness and retinal bleeds. These are the consequences because of hypertension per se. Another one, because of the therapy to lower the blood pressure. It can cause hypoperfusion of vital organs, resulting in acute kidney injury, seizures, transfer ischemic myelopathy, transient or even permanent visual loss, sometimes death. So that needs to be avoided. Number one, avoiding high blood pressure causing end organ damage and also precipitously lowering blood pressure because of the medications to prevent hypoperfusion of the vital organs. The long-term prognosis of children depends on the long-term blood pressure control, medication adherence. The most common cause for acute severe hypertension in adults is non-adherence to the medication prescribed. Even severe hypertensive target organ damage, such as severe left ventricular hypertrophy, retinal angiopathy, usually reversible if you control the blood pressure appropriately. In general, prognosis is good if severe hypertension is not long-standing, acute therapy is appropriate, and the underlying disease is effectively treated. Conclusions. Hypertension crisis is a life-threatening event. Causes are usually secondary in children. They all need to be treated in pediatric ICU. The main treatment strategy principle: reduce blood pressure safely to prevent hypoperfusion of vital organs. Thank you so much.